Muy buenos días, tengan todos. Bienvenidos a esta sesión sabatina de la Agrupación Mexicana para el Estudio de la Hematología. Hoy tenemos un programa extraordinario, excelentes años, con muchas preguntas, nuevas preguntas, después de varios resultados. Tenemos a tres verdaderos expertos en esta ocasión, que el hacer la sesión sabatina en sábado, en este día, nos permite tener profesores extranjeros de Europa, como el doctor Foix, que varios speakers y médicos hematólogos de gran trayectoria en el tema, disfrutar esta sesión tanto como nosotros en la mesa directiva. Y sin más por ahora, le dejo la palabra a la doctora Demichelis para que nos haga la presentación con mayor detalle del programa de esta mañana. Adelante, por favor.
Bueno, buenos días, bienvenidos a todos a esta sesión sobre linfomas indolente, que además pues es en el marco de que septiembre es el mes de la concientización sobre cánceres hematológicos. A nombre pues de toda la mesa directiva y ponentes, pues recordarlos que ya cada vez está más cerca nuestro congreso a final de octubre y que pues este es uno de los talleres que vamos a tener precongreso. Vamos a tener 3 talleres distintos que podrán elegir a cuál inscribirse, y uno de ellos es pues justamente un acercamiento a horas. Y pues ya para presentar nuestra agenda del día de hoy en nuestro brunch con los expertos, tenemos una agenda muy interesante y 3 grandes ponentes que van a estar con nosotros, pues al menos virtualmente. Vamos a empezar con el doctor Foix, que pues seguramente todos ustedes conocen. Ahorita lo presentaré más a detalle, pero él nos hablará del papel de la enfermedad mínima residual en el manejo de los linfomas no Hodgkin indolentes. Después tendremos a la doctora Lori Leslie, que tratará de responder en una charla esta pregunta sobre si sigue siendo la observación una opción en los linfomas indolentes. Y la tercera charla será y les voy a presentar un poco sobre nuestros ponentes. El doctor Foix está en la se formó en la Universidad de Torino y actualmente es director de la División de la Hematología de la Universidad Sapienza en Roma, profesor de órdenes linfoproliferativos del GIMEMA, autor pues de más de 600 trabajos. Sus áreas de interés pues mucho tienen que ver con los trastornos linfoproliferativos. Como todos sabemos, también la leucemia linfoblástica aguda le apasiona y de hecho nos acompañará en noviembre en otra sesión, educación en hematología en todo el mundo, y es además un gran fotógrafo que ya nos podrá platicar de eso, y lo tendremos en unos momentos con nosotros. Después tendremos a la doctora Leslie, que ella es hemato-oncóloga formada en el MD Anderson, es actualmente directora de los programas de investigación en linfomas indolentes y leucemia linfocítica crónica en la Escuela de Medicina de Hackensack Meridian, profesora asistente de dicho centro y codirectora médica en oncología, autora de múltiples publicaciones. Charla tendremos al doctor Gilles Sal, que es hematólogo-oncólogo por el Hospital Universitario de Lyon en Francia, jefe actual del Servicio de Linfomas del Memorial de esta Asociación de Estudio de Linfomas, autor de múltiples publicaciones, editor de ellos, incluida la inmunoterapia en linfomas. ¿En qué idioma quieren escuchar las charlas? Ya sea en el idioma original, vayan teniendo, las vayan subiendo a pues el área específica de preguntas y las haremos. Y finalmente pues quiero agradecerles al equipo de Sandoz por el y bienvenidos todos este sábado por la mañana.
So good morning for you. It's a good afternoon for me, but good morning to all of you. Colleagues in Mexico who invited me to be with you today and to talk in a session of the role of minimal or measurable, as we often use the word measurable today, residual disease in a manageable indolent non-Hodgkin lymphoma. So this is a bit of a, what can I say, not a very frequently discussed topic, because MRD is certainly something extremely important in many hematological malignancies in this 30 minutes or so of my presentation. So going on, I don't know if you want disclosures or not, but anyhow, a few disclosures are here. Now, I thought I would start by putting the situation of MRD in context, because I think nowadays it is very clear that monitoring of minimal or measurable residual disease is highly clearly in ALL, both in children and in adults. MRD negativity should be a primary endpoint of treatment. And in fact, I always use should is how much is MRD actually doable? But that is an important point. But certainly in ALL at all ages, MRD negativity should be a primary endpoint of initial treatment. And indeed today it guides treatment not only of drugs, but also of lab technologies. What is clear in ALL that this has a clear impact on the outcome of patients. So it's not just an option, it's not research, it should be implemented. Leukemia. A lot of data also another subset of AML, largely by leukemia. I think it's very clear that MRD monitoring has in CML. Then I put CLL/small lymphocytic lymphoma also because CLL, what we do know is that patients who become MRD negative do certain of treatment. It's in clinical trials. If you become MRD negative, you tend to do better, but it should. This is an important message. You can become MRD negative. This has an impact on prognosis, but today it's not in the guidelines. It's not MRD negative do better, but again, this is not an end to say that for many conditions in hematology, MRD is currently used for MRD monitoring, which I will discuss also later. Flow cytometry is certainly the most widely used. If you think about small lymphocytic lymphoma CLL, this is how we usually monitor, although you can, and it's probably more precise, do also quantity PCR monitoring for immunoglobulin or T-cell receptor gene arrangement and in acute leukemias or in CML for known gene fusions. So this is something, for instance, in ALL, this is what you do. The standard should be RQ-PCR, which is more sensitive than flow cytometry. Then there are more advanced technologies that are continuously developed and refined. And these have already had an impact in different conditions in hematology. And these aim at refine. You can also have next generation sequences. And these advanced technologies have shown a clear role in childhood and adult ALL, in non-Hodgkin lymphoma too, in follicular and mantle cell, and in myeloma patients. So we are refining technology, although the standard, at least in acute leukemia in ALL, is still quantity PCR. Another potential development is that of the so-called liquid biopsy, aimed at monitoring circulating tumor DNA. And this may also help to further refine MRD monitoring. It's not consolidated yet, and I'll have a slide also on liquid biopsy. Now, one question, I'll bring this up at the end too of my talk. How doable is MRD monitoring in a real life? Now, in order to carry out an accurate MRD monitoring, this requires a broad and complex assessment like diagnosis. So it's more complex than only diagnosing a condition. If we want to do MRD, we have to extend our characterization, for instance, by flow. It means that the panel of antigen used has to be larger and dedicated also to identifying the combination useful to monitor that given disease, typical in CLL, small lymphocytic lymphoma. And clearly genetic characterization. If you want to monitor a known fusion gene, you have to identify it. So you have to have a broader characterization of the genetic landscape of a given disease. Example, typical ALL. Important methodological aspect. This requires or should require the availability of certified laboratories and the use of decide, for instance, I put this in bracket, to transplant or not a patient based on MRD, we have to be sure that the MRD has been carried out in a standardized way using certified technologies. So this is extremely relevant. Often we need sequencing technology, which are not widely available. Ideally, this probably should be done in central laboratories. If you have multi-center studies carried out for different conditions, then you very often have central laboratories for the characterization and diagnosis and also for monitoring of the. This should be done in central laboratories. all more relevant as I mentioned, as treatment decisions are to be taken. I mean, if you want to use, I don't know, think about blinatumomab in ALL. And the bottom line of all this is that prognosis, management, and outcome can significantly change if adequate and standardized MRD technologies are readily available. And the reverse of it is that if you don't have them, then there is a problem because we're probably not offering the ideal management for some diseases in the field of hematology. So that is a bit as a background of what I wanted to say. And now I'll go a bit more specifically into indolent lymphoma. And as I wrote in the slide, if we exclude the CLL/small lymphocytic lymphoma, the key player in the field of indolent Hodgkin lymphoma is follicular lymphoma. So in fact, apart from CLL, I will talk here about follicular lymphoma and what we've learned and what is the actual situation as I see it today. So the topic in general that I've been asked to cover is, does MRD have a role in the management of indolent? And here I'll talk about follicular lymphoma from this point onwards. And I will try to cover 5 aspects, which you see indicated here. So the first is the molecular tumor burden at diagnosis useful to stratify patients in risk categories? The second aspect I will cover is MRD useful to predict survival, progression-free survival, and even perhaps overall survival. And 4 is a prolonged molecular follow-up of clinical relevance. And the last, number 5, can we use MRD to modulate treatment? This is what we do in other diseases. Could this be applied to follicular lymphoma? So I'll try to cover these 5 aspects. So let's go to the first one. Is molecular tumor burden at diagnosis useful to stratify patients in risk categories? Now here are data from advanced follicular lymphoma patients, progression-free survival. So here, and this will be a theme that I will cover throughout my talk, you see data from different published studies, and you can see the references written in the different slides. And they go back many years. This is in fact a study that we conducted in Italy. You see, published in Blood in 2005, so that's a long time ago, where we did quantitative PCR on bone marrow samples at diagnosis. And what we found is that if you have a high tumor burden, patients do less well than if you have low levels. In fact, here it was not too different between intermediate and low. You can see the curves here. If you have a high tumor burden, they did significantly. These are all significant curves. This phase 3 study, now FIL is the Fondazione Italiana Linfomi. You speak Spanish, so you understand what I'm saying. And this was a phase 3 study published in Blood in 2013. And you can see that the 3-year progression-free survival was 66% for patients with a high tumor burden versus 75% for patients with intermediate versus 80% with low. So there is a difference, and this particularly for the high tumor burden patients. There's another study published in Blood in 2015. This is peripheral blood quantum PCR. And here, again, if you have a high tumor burden down here, patients do significantly less well. This is another, the fall 05 study by FIL. This again on bone marrow, 3-year progression-free survival is 59% in high and 80% in low. So the tumor burden at presentation has in fact a prognostic implication, which may be not surprised. It means you have bigger bulk of. Now, what about localized follicular lymphoma patients? So this is a study in a localized patient. This is from our institute in Rome, published in British Journal a couple of years ago. And the tumor burden molecular quantification at diagnosis was done by, let's say, conventional quantitative PCR, which is panel 8, and by one of the more modern technologies, the droplet digital PCR, panel B, the PCR. You can see the curves here. B is more significant than A. So this is really something interesting, because it shows you 2 messages. One, that in localized follicular lymphoma quantification at diagnosis may have a prognostic impact, and that more modern technologies may refine the molecular quantification. So I put the data together. It is fair to say, you see it here down at the bottom with the arrow, that both in advanced and localized follicular lymphoma, quantification PCR predicts progression-free survival, being in fact an independent prognostic marker. So that was for number one. And the number two question that I would like to address is, as I mentioned, is MRD useful to refine the clinical response to treatment? So again, I'm giving you examples from different studies, but the bottom line is more or less simple. This is from one of the field studies, a randomized study, and you can see here the 3-year progression-free survival was 77% overall, and particularly for the patients who were incomplete hematological remission and MRD negative. It was lower, and you can see the figures here, 59 and 45%, if it wasn't a complete response, if you had either a partial response and you had MRD. So what the bottom line is that MRD can refine clinical response to treatment. MRD predictive value is superior to clinical response in multivariate analysis. This is in different studies. And to add a bit to this, there's also MRD combined with PET. So what came out from the combination of these two is that patients who are PET negative, MRD positive, PET MRD negative, showed a 2.1 higher risk of progression of death than the patients who became, after treatment, PET negative, MRD negative. Although we still progress. But certainly I think it is very clear that MRD can refine the definition of response to frontline treatment in follicular lymphoma. If you look at the chemoimmunotherapy area, we're talking about chemoimmunotherapy with rituximab, the standard for many years. And rituximab, as we all know, and you'll hear this from Jill Sound, who was the pioneer of the studies with rituximab, MRD negativity at the end of induction treatment goes up to 70–80%. If instead of rituximab, we use GA101 or Fatumo, the second generation anti-CD20 monoclonal antibody, you see the MRD negativity at the end of induction treatment goes up to 90%. So you can have a higher rate of MRD negativity if you add the second generation anti-CD20 monoclonal antibody. So MRD analysis represent certainly a sensitive tool to refine clinical response definition in follicular lymphoma. And the important point, I think, is that I mean, we have data already, but it's something that is now being actively investigated. Let's go to number 3. The number 3 question that we addressed is, MRD useful to predict progression-free survival? And I'll show you overall survival too. So here, progression-free survival in clinical trials with no maintenance treatment. And again, there are many studies here. And again, this goes back to our old study in Blood 2005. And you can see here the PCR at the end of induction treatment. And you can see that it was, if you became MRD negative, the patients free from relapse was 64% compared to 32%, so doubled. And this was highly significant. So already almost, well, and this has been shown in other studies without maintenance. This again, a field phase 3 study published, as I told you earlier, 2013. And you can see the 3-year progression-free survival was 72% in the MRD negative and 39% in MRD positive. This is another study, Hodgkin lymphoma 1, the field study, it's the same, and here the 25% advantage becoming MRD negative. So it's very clear that MRD can predict progression-free survival in these protocols which had no maintenance. And what about maintenance? So this is MRD capability of predicting progression-free survival with maintenance treatment. Look at the data, and the message is that maintenance either maintained or increased the rates of MRD negativity response. And more in detail, the message are that 2/3 of MRD negative responses could be preserved throughout maintenance. No differences between the two arms. in a rate to conversion to MRD positivity. You see about 6% with both arms, so no real difference. Within MRD positive patient at the end of induction treatment, 92% of patients in the G chemo arm, so fatumumab, and 78% role, as we know. Important, a few cases who were never became MRD negative rapidly progressed. Here, there's another piece of information that MRD was also assessed at the middle of induction, at an earlier time point. It's something that has been done in many diseases, in ALL, childhood first, and in adults, in chronic myeloid leukemia. Early response is usually a good indicator. So here, this has been done at the middle of induction, and progression-free survival was significantly longer for peripheral blood MRD negative versus MRD positive at the middle of induction. It's highly significant. So the message that early responders had the best prognosis. So this is another piece of information, not only that MRD may play a role, but the depth and rapidity of response also are important. CHOP versus R2, that is Revlimid plus rituximab. So no chemo here. And here overall, at the 3-year, if you look at MRD, the 3-year progression-free survival was 84% for patients who became MRD negative compared to 55% for patients MRD positive. And these data from the Gadolin study, which was for relapsed refractory follicular, so not frontline, relapsed refractory, comparing G-Benda versus Benda alone. And here again is a middle for MRD negative compared to 47% in with the bendamustine. At the end of treatment, G-Benda did again better and significant. The treatment arm and flibutator strongly predicted progression-free survival. So again, MRD is a key point, even in relapsed refractory patients. What about a long follow-up? But I put together data here that have been accumulated in the last few years. You see between 2018, 19, and 20, there's an English study, Italian study, and the Gallium study too. For the UK study, it's 11.4 years. For the Italian GITMO study, 13 years. And for the Gallium, it's short at about 5 years. But if you look at negative status compared to 12.5 years for patients who remain or re-become MRD positive, and this is significant. For patients who became MRD negative in the bone marrow versus 52% for patients who are positive. This again is a big difference. And the Gallium study is also significant. You see between MRD negative at the end of induction versus MRD positive, there is a significant difference. So I put it together. I think it's fair to say that, MRD negativity is predictive of a better progression-free survival in all clinical trials conducted in the last 2 decades, with or without maintenance, even in relapsed patients, and possibly of a longer survival in studies with a prolonged follow-up. Assessment already at earlier time points, the middle of induction, as I mentioned, compared to end of treatment or induction, particular follow-up of clinical relevance. This is not a single definition, but multiple evaluation of MRD, something that we routinely do in acute leukemias, but less maybe in lymphomas. And this is obviously something important because you can have multiple different responses. See here that the 3 negative, and these patients may be doing very well. So this was investigated in one of the field studies, and the bottom line was that accumulation, not only a single, accumulation of MRD negative results over time reduced the identified with multiple determination. The problem is that the timing of clinical relapse is not accurately predicted by the current MRD analysis. So you probably need a kinetic model of MRD analysis, more than one single result. This may help in anticipating this recurrence. And we'll get more information on this point. Now, the last point I want to touch upon here, number 5, was can we use MRD to modulate treatment? We've shown that MRD response certainly has a prognostic value, but can we use MRD blood in 2002? This is when there was no rituximab added in induction. It's at the end of CHOP. The bone marrow MRD negativity was 36% of patients, at week 12, 74% at week 28, and 63% at 44. And this has an impact. PCR negative patients did better than positive. So, lymphoma, we learned that rituximab can convert MRD positive patient into MRD negative after chemo alone. So this is the old treatment with a clinical 12 study that were presented at ASH last year and have been recently published in the JCO. Very large study with a standard arm of 2 years of rituximab maintenance, experimental arm put together MRD and the metabolic response. What came out is that the standard arm had a significantly better progression-free survival than experimental arm. And I give you more data in this slide here. These are the data and message from the study. Message are that punctual MRD analysis predicted a poor outcome at multiple pre-planned time points. So this is more than one quickly. The latter being preferable as broad use and international. Quanti-PCR is better. Bone marrow allows a better prediction at the early time point, but starting from month 12, this is interesting. After end of induction treatment, peripheral blood seems to be superimposable to bone marrow, allowing effect. And the high predictive value of punctual time point analysis further improved by kinetic approach to the interpretation of the results. Now, studies. So this is a study that we did, in fact, in patients had an MRD negativity in 50%. But what we did that the patient were MRD positive, we gave rituximab. And they do better. So again, rituximab can convert MRD positivity into MRD negativity after radiotherapy. And this, the so-called field mirror study, again, for localized, you see stage 1 and 2 follicular lymphoma, local radiotherapy, and patients who were CD20 but ofatumumab, so no longer rituximab. And what was observed that a conversion to a MRD negative status, which was the primary of the study, was achieved in 22 of the 24 evaluated patients. That's at 92. The impact on survival or progression survival, we don't know yet. It's too early. It's a very indolent disease, so we need more time. But this could be a further way to impact in indolent lymphoma. So can we use to moderate treatment MRD? Let's put it together. I think it's clear that rituximab maintenance holds and increases rates of MRD negativity. This seems to be clear. Two recent trials by Phil, FOL12 and Miro, explored the medication in MRD positive and MRD negative patient at the end of induction, respectively. And one single molecular response is probably not sufficient to indicate disease eradication and the intensified treatment. So this leads me towards the end. I have just 2 or 3 slides to discuss a few points. I think where are we going? I mean, I think this is the research and future of MRD in non-Hodgkin, indolent, and maybe no patients having the molecular marker. So the aim is to try to find a marker for every individual patient. And maybe to improve the possibility of using non-invasive tools to study MRD, and therefore to apply MRD to all non-Hodgkin lymphoma. Now we have standard and new techniques. I've mentioned this. Certainly we have the peripheral blood and the marrow. What about plasma? I mentioned plasma earlier. There's another option. So you can maybe use plasma, question mark. We'll discuss it. Quanti-PCR, next generation sequencing, digital droplet PCR, all these are starting to be considered with some important, interesting observation. Marker for each patient, this is still investigation. There are data published, but this technology may not develop further, but this is something we have to do. And now with AGS technology, this probably will develop, we will see. And the hope is to find clonal arrangement in every patient. We're not there yet, but this is obviously research, and this is something we need. I mentioned droplet digital PCR. This has been applied a lot to ALL, for instance, but also in lymphoma. And what is very important, these are samples which have a signal, but we don't know if this is a disease or just a background. And the more sensitive technology are very valuable. The droplet digital PCR has been applied, and you can see it here, and the papers have been published. High still not quantified. So this is probably going to change the terms. Circulating tumor DNA, liquid biopsy, a lot of hype. This is certainly very interesting to define the genetic landscape of lymphomas. A bit more complicated for MRD, but there are attempts to use it also for MRD in hematological malignancy, but we are not there yet. So final comments, and then I have two more slides or one. Despite several decades of lymphoma in CLL and in follicular lymphoma. However, having said all this, with all the data I showed you, and hopefully I convinced you, we have to say that MRD analysis has so far not entered the day-to-day clinical practice. It's not in the guidelines, it's not requested. In fact, outside of clinical trials, MRD results should not be used to take clinical decisions in a real-life management of follicular lymphoma patients, as also in CLL, small lymphocytic lymphoma, and even in hairy cell leukemia. So one thing is that, so what happens? In order to move MRD in follicular lymphoma from clinical trials into the daily clinical practice, further studies are needed to overcome the limit represented by the lack of a molecular marker for all these patients, for all patients. This is obviously a limit. If we can use it only in a proportion patient, this is a major limit to apply these technologies. We need to establish an integrated risk stratification where MRD is responders, candidates to experimental approaches, to explore other MRD-adapted treatment modalities, possibly with kinetic model to MRD, sequential repeaters. To evaluate if chemo-free combination have an advantage in terms of MRD achievement compared to chemotherapy. I gave you some data from the R2 study, but we need more data. What I think is fair to say, data mature to design MRD-driven clinical trials that incorporate the molecular monitoring in the management of follicular lymphoma patients. And result from new generation trials. When I said at the beginning, how doable is MRD monitoring in the real life in hematology in general, not only in follicular lymphoma, even in situations where MRD should be done, is all, I'm not repeating because time goes by, is all less doable. And I put it at the end, this I did not have in the earlier slide. I put it here with the arrow in red. We have very important issue of accessibility and sustainability. Do we have laboratories available? Are they standardized? Do they use certified technologies? Do they have quality controls? And who pays? This is a reality around the world, and we have to face it. Not all people always talk about the cost of drugs, but it's only. So I leave this to you because this, I think, is a key point in lymphoma, obviously, but let's keep in mind that we don't need it yet in the real life, but certainly in hematology. So the networks, as I mentioned or alluded to, are a key for success. We have this in Italy. We have the Italian Foundation for Lymphoma. We have many working groups within this as an MRD network operational in Italy. Different laboratories are working on this. One in Turin, one in Pisa, one in Aviano, and one at our center in Rome. And this is also done within the EuroMRD guidelines. So again, there's quality controls that circulate to show that you're working correctly. So this for your attention.
Well, thank you guys very much for having me. My name is Lori Leslie. I am from Hackensack, New Jersey, United States, where I'm a specialist in lymphoma and chronic lymphocytic leukemia at the John Theurer Cancer Center. There, I play a large role and run the indolent lymphoma and CLL research programs and do a lot of CAR T-cell therapy as well. And today I'm very thankful to be invited to speak a little bit about the topic, is observation still an option in indolent non-Hodgkin lymphoma? And when I first got this topic, I realized I could be quite brief and just say yes. But we'll go into a lot of details, and then I'm excited to discuss with you guys at the end how we could potentially, move the field forward, as we were talking a little bit about MRD and things that may play a role in this topic as well. I've included some disclosures here. So lymphoma is complex. I feel quite lucky just to focus on that. And the treatment landscape is very rapidly evolving. With first in the Rituxan era, at least in the United States, it was approved in the era. Long-term outcomes have improved with the use of this targeted monoclonal therapy, adding immunotherapy to chemo. And the treatment landscape has continued to really evolve towards talking a bit more about treatment in the next session. One main question we have remains, and that is, with these novel therapies coming into the treatment landscape currently, is watch and wait still appropriate for a majority of patients? And the other question that we'll be able to answer a little bit more as we go through the discussion today is, are recommendations uniform across indolent? But we'll go through a few exceptions to the usual watch and wait type of suggestion for people with asymptomatic disease. When I see a new patient in clinic, I like to explain that lymphoma is not one disease. There's over 80 subtypes in the most recent WHO classification. About 90% of patients are non-Hodgkin, and the majority of those have B-cell non-Hodgkin. And then we divide it as indolent or aggressive. So indolent lymphomas, the most common type is follicular. Aggressive lymphomas, the most common type, diffuse large B-cell, with a chance of transformation of about 1 to 3% per year. And so within indolents, we have follicular, marginal zone, SLL, lymphoplasmacytic lymphoma, Waldenstrom. And sometimes through this just to highlight, it's getting more and more complex. And historically, all of these subtypes were lumped together in clinical trials of indolent lymphoma. And as we've shifted into the targeted therapy era, we're appreciating that the pathobiology of these diseases may be different, and that we should be investigating them as individualized diseases rather than indolent lymphoma. The pathways that have been found to be important in the biology of indolent lymphomas. And one example of differentiating activity here are the BTK inhibitors. So we know that, at least in the United States, these have approvals in marginal zone. Mantle cell lymphoma are the preferred frontline treatment for Waldenstrom macroglobulinemia, the BTK inhibitors. However, in follicular lymphoma, they really don't have much activity, and there's no indication to use BTK inhibitors in follicular lymphoma. So that's just one example of all these targeted therapies being different in the indolent lymphomas. And though currently unfolds, hopefully we'll be able to identify patients that may need earlier initiation of therapy that we currently are recommending a watch and wait approach. And just this is a schematic we will not go through in detail, showing the complexity of indolent lymphomas. And this again is looking at the treatment landscape in the United States. We're shifting targeted therapy earlier and earlier in the treatment landscape. And some therapies are actually coming off the market. For example, the PI3 kinase inhibitors, due to toxicity concerns, have recently been, 3 of the 4 have recently been withdrawn from the market in the United States, at least in the case of follicular lymphoma. So with that general landscape in mind, and again, the details of treatment will be discussed, I believe, in the next. Do they have symptoms? And do they have an opportunity for potentially curative intent therapy? We think about indolent lymphomas as chronic diseases. Some people say, it's a marathon, not a sprint for these patients. They have the opportunity to potentially relapse 10, 20, 30 years down the line. So they need to be monitored long-term. And many patients with advanced stage disease have an experience in which they treat when symptomatic, experience a treatment-free interval, and then may need treatment again. And each period of remission typically is slightly shorter. So in this long-term approach, which is what we currently have with our available therapies and current knowledge, really it's, does a patient have symptoms, and does a patient have intent for potentially curative therapy? A bit more detail as kind of the example of indolent non-Hodgkin lymphoma, and then talk a bit more about marginal zone lymphoma, mantle cell lymphoma, and very briefly Waldenstrom, just to talk about a few exceptions and nuances of patients that may be appropriate for treatment when otherwise you would watch and wait, and vice versa. There's many different kind of definitions of what symptomatic is in patients with something commonly used. BNLI is another set of criteria used to determine whether or not someone with follicular lymphoma is symptomatic. And this is really just speaking about advanced stage. So symptoms include patients that have bulky disease, and the definition for GELF that we most commonly use in the United States is greater than 7 centimeters, 3 sites greater than 3 centimeters, or a spleen that's so large that it's creating symptoms, usually around the area of the umbilicus. Organ involvement, which is compression syndrome. So even if you don't have bulky disease, but you're worried it's going to cause hydronephrosis or another organ issue, that's an indication to treat. If patients have ascites, pleural effusion, these symptoms, cytopenias, or leukemic phase, those are patients that you should consider therapy. Another important component of that is disease are changing such that you're worried maybe they don't have compression syndrome, but they're at risk for developing that in the near future. That may be an indication for treatment. And each of these indications aren't like a light switch. They're not a yes, no, black and white type of thing. I certainly have patients that have 3 lymph nodes or more in like the 3 to 4 centimeter range, but have been stable for over a decade without any therapy. And I also have patients that maybe have relatively minimal disease, but it's bothersome to them in their day-to-day life. You know, maybe some cervical adenopathy that necessarily meet these classical criteria for symptoms. So there's a lot of criteria that can be used as guidelines, but I find one of the challenging things about managing indolent lymphomas, and something that's quite variable practice to practice and culture to culture, to be honest, is when do we start treatment in some of these gray areas. One variable, you've got your grade 1 to 2, that is your more standard, indolent type of lymphoma. Then you have grade 3B, which is at the opposite end of the spectrum, and that's your more aggressive follicular that typically behaves more like a diffuse large B-cell lymphoma. And those patients, we typically don't watch and wait, but initiate challenging. And actually, the NCCN guidelines do not even have a guideline for grade 3A follicular lymphoma. What is recommended is to take into account the clinical characteristics, the patient's presentation, and then appropriately. So a lot of heterogeneity, and it's very, very important also to hunt for the transformation. So I mentioned very briefly before that patients with indolent lymphoma have a 1 to 3% chance per year risk of transforming to a more aggressive lymphoma. Have a patient with low grade and the SUV of one of the lymph nodes on the PET scan is higher. It's very important to go ahead and try to biopsy that sample and make sure we know what we're dealing with before there's even a discussion of potential watch and wait, because that transformed patient criteria that apply to follicular. And this is really expanded to many of the other nodal, indolent lymphomas like marginal zone. If, they're asymptomatic, you watch and wait advanced stage. And we'll see that situations in which we have data that there could be benefit of intervening earlier for an otherwise asymptomatic patient. And one example here are some data from Lancet Oncology in 2014, looking at the use of rituximab monotherapy in patients with advanced stage, 379 patients, looking at either Rituxan induction alone or Rituxan plus rituximab induction plus maintenance, or watch and wait. And then later, the rituximab induction was closed, and it was mostly induction plus maintenance. That was just in wait. Did delay time to new treatment, time to the patients needing cytotoxic therapy. So it delayed cytotoxic therapy, not surprisingly delayed progression-free survival, but it did not change longer-term outcomes such as overall survival. So if patients waited until they needed treatment and started treatment later, that did not affect their overall survival. And also, there was no impact, increased the chance that the patient could have a transformation event, which is typically more challenging to treat. And the answer to that is no. So we're delaying onset to cytotoxic therapy, but not changing long-term outcomes. What else might be a reason to treat? So the patient's quality of life. I find this very variable in my practice, and on panels of other people throughout the world who treat follicular lymphoma, it does seem to be quite variable regionally, different cultures, different countries, about how generally patients feel about watch and wait when you have active disease. So here in the United States, patients tend to be a little more common. Lung cancer is common. Lymphoma is relatively uncommon compared to those diseases. So most people have friends with other types of diseases that you don't watch and wait. And the concept of having a cancer that we're going to not do anything about is very unsettling to them. So one thing they looked at in this study, rather than watching weight, improved some of the cancer adjustment and coping and illness coping type quality of life scores. So if a patient feels very nervous about watching weight and it's something that's really impacting their quality of life, there are data to support that this is a reasonable approach that could be considered when you would otherwise recommend observing a patient. So that's advanced stage with, mostly watching weight unless you're symptomatic with some few exceptions or opportunities. Now we'll talk about early stage. And these are the patients that potentially have an opportunity to get minimal therapy and have a long-term remission. I'll mention actually back at this slide for a moment, the risk benefit of treating with rituximab. Rituximab is associated with kind of minimal side effects. So that's why that due to the added side effects, tends to favor observation with the addition of chemotherapy. Similar trend here in early stage. So, with stage 1 or localized stage 2 follicular lymphoma has a potential that eventually cured. So radiation, especially if it's in a site with minimal risk of toxicity, is a very reasonable approach, and patients have an opportunity for potential cure. There are data about adding a CD20 monoclonal antibody to radiation, and there are data that can increase the rate of cell-free DNA or MRD eradication. What that means longer term, as we heard in the last talk, who knows? But that would be one opportunity also. And that may also improve failure-free survival. But again, there's no difference in overall survival seen with the addition of a CD20 antibody. So really, it's considered controversial and can be considered because there's minimal added toxicity. But these studies of adding things like CHOP without rituximab, so just chemo without immunotherapy, does not show any improvement due to probably the added toxicities of adding chemotherapy. So really radiation alone, plus or minus a CD20 antibody, is considered the standard of care for localized stage 1, with a 10-year PFS rate of radiation alone of up to 60% and a 15-year PFS rate of up to 66% in stage 1 and 26% in stage 2, seen in various different studies. What are the exceptions to that? So stage 1, 2, we typically treat, but not everyone. So one example of when you could consider observation instead of treatment in early stage follicular lymphoma is someone who's had a completely resected lymph node. So an example of when I see this pretty commonly is, a woman went for her regular mammogram and then was found to have an axillary lymph node that was mildly enlarged, ends up getting an excisional biopsy where they take the entire lymph node, and that shows a low-grade follicular lymphoma. We do care to the site. Or observation. And this is some data from a study in which patients had completely resected stage 1 follicular lymphoma with over 6 years of follow-up. And it showed that the rate of local relapse was around a quarter of patients, distance relapse around a quarter of patients. And of those patients that had a local relapse, and it doesn't seem like you kind of lose anything in that situation if you delay the radiation only for those patients that develop a localized relapse. And about half of patients didn't need any further therapy, though for follicular lymphoma, 6.3 years is relatively short follow-up. There's other data that patients that have not had completely resected disease, so maybe had that axillary lymph node or whatever and just had a biopsy, stage 1, 2 disease, and these patients did not have completely resected disease, but observation instead of radiation or another therapy was recommended due to various concerns, whether that's the radiation field where overall survival independent of the lymphoma was felt to be relatively short. So this is looking at those patients, and you can see at 86 months follow-up, which is pretty long follow-up here, 2/3 of the patients almost remains untreated. And for those patients that did need treatment, the median time to therapy was nearly 2 years. So very reasonable approach for patients. If there's any concern about the location, a few years out, almost 2/3 of patients remain treatment-free. Looking at longer term outcomes like 10-year survival or projected 10-year survival, you can see here. And the top line in the chart is this study. And then you can see many other studies listed here. See the 10-year overall survival is very similar across the board. So it doesn't seem to be impacting long-term outcomes. So with those thoughts about advanced stage and early stage follicular lymphoma in mind, we can move on to some details about marginal zone lymphoma. And we're learning a lot and really subdividing marginal zone lymphoma a lot more in recent clinical trials than what was done even 5 to 10 years ago. Marginal zone lymphoma is less common than follicular. So of the 80,000 new non-Hodgkin lymphoma cases per year in the United States, about 25% are follicular and 10% are marginal zone. But among those marginal zone, you've got your extranodal. Due to the rarity and heterogeneity of marginal zone, it's been hard to study. But again, now you're seeing in the target therapy era, a lot more studies that look at marginal zone specifically. The pathobiology of marginal zone is different than follicular, and there's chronic antigen and antigen malt, Campylobacter with small intestinal malt, and some other examples that I have listed here. Autoimmunity is another form of chronic inflammation, chronic antigen-mediated B-cell receptor pathway activation, and patients with autoimmune diseases also have an increased risk of lymphomas, including marginal zone lymphoma. So I see a lot of patients, from the rheumatologist who have been then diagnosed with marginal zone lymphoma as well, and their autoimmune disease is important in the pathobiology of their lymphoma. Any other chronic inflammation, common variable immunodeficiency are also things in which we see increased incidence of marginal zone lymphoma. Then there's also the antigen-independent B-cell receptor activation, and that's a little more important in the nodal and splenic marginal zone lymphoma pathobiology. So I'm not going to go through everything in the same, level of detail as follicular, mostly because a lot of the concepts apply at least to advanced stage disease. In patients with advanced gastric malt, which is the most common type of malt and the most common type of marginal zone lymphoma in general, if they're advanced stage and asymptomatic, observe. When you have gastric malt, one kind of nuance there is if involvement that seems to be at risk for GI bleed or they present with a gastrointestinal bleed, that would be one indication to go ahead and treat that symptomatic site when overall you're going to observe the patient otherwise. So that's one kind of nuance about your gastric marginal zone that doesn't commonly apply to follicular lymphoma. Talking about localized disease, H. pylori testing is very important, should be done for all patients, at least according to NCCN guidelines. That is done on the histology, the biopsy, but then also serum antibodies are recommended, your IgG and IgM for H. pylori. I don't find even in the United States that that's done very commonly, and I'm not sure, in other countries if that's part of the H. pylori workup. But if patients are positive by either of those modalities, then treatment is recommended for the H. pylori, whether or not they have localized or advanced disease. In the case of H. pylori positive localized gastric malt, that is either negative for translocation 1118, which is one of the hallmark translocations of malt, or unknown, not tested, then it is recommended to treat the H. pylori, of course, and then observe. And this is because patients can go into a spontaneous remission if you have localized gastric malt with H. pylori testing alone. You're getting rid of the infection of the chronic inflammation, and those patients can go into remission without any other therapy. And that doesn't happen immediately. It can take as early as 3 months. It can take a year and a half. And some studies show that 10-year failure from further treatment is up to 90% in patients that have localized H. pylori associated gastric malt. So that's observation because treatment of the infection alone may lead to spontaneous remission. If they're H. pylori negative or do have the translocation 1118, H. pylori negative, of course, is unlikely to respond to antibiotic therapy, and the translocation 1118 is associated with a less than 5% response rate to antibiotic therapy, even if H. with long-term excellent response rates. The same exceptions here are what we talked about before. So if their radiation is contraindicated for any reason, rituximab monotherapy can be considered. If it's very minimal disease and there's no concern for GI bleeding, then observation would be appropriate in that patient, even though they have early stage disease. I'm actually going to go back to splenic in a second, but non-gastric malts are a little bit different. They're less common than your gastric malts. And a lot of this also applies to your rarer nodal marginal zone lymphoma. I'll say most patients with marginal zone lymphoma that present with lymphadenopathy don't actually have nodal marginal zone, but it's more an advanced presentation of one of the other subtypes. But for non-gastric malts, again, you can think of radiation alone with some site-dependent variability in terms of response rates. You can consider rituximab if, for whatever reason, the site or the patient is inappropriate for radiation. But observation is also, appropriate, as we talked about. And one detail about the non-gastric malt lymphomas that doesn't necessarily apply to some of the others, or that we talked about, I guess, with follicular lymphoma, is surgery may be considered. So if you can do complete resection of a lung, a breast, a thyroid, a colon, or if you have a patient with cutaneous marginal zone lymphoma that's completely resected, observation is very appropriate for those patients after they've had a complete resection. So that's similar to what we talked about in completely resected follicular lymphoma. And then advanced stage patients are treated the same as other, indolent lymphomas, observe if asymptomatic. Splenic is different. There's really no early stage. These patients have splenomegaly usually and bone marrow involvement, and that tends to be it. And similar to what we talked about with H. pylori and gastric malt, hepatitis C is important in the pathobiology here. We screen all of our patients for Hep B, Hep C, HIV in general with lymphoma, but in splenic marginal zone, if patients have hepatitis C and it's treated, similar to treating H. pylori and gastric malt, you have a chance for spontaneous remission. So it's recommended to treat the hepatitis C, reobserve, and then really restage, and then observe, and really only treat if a patient has symptomatic splenomegaly or if they start to develop cytopenias from their disease. I will also say in general with the indolent lymphomas, follicular lymphoma, one reason, again, to watch and wait patients who are asymptomatic is there is in some studies up to a 10% chance that they will go into spontaneous remission without treatment. And that can be long-lasting over a year. Some patients that I can think of that I've had who've experienced spontaneous remissions, it tends to happen after the biopsy. So it could be that, and those patients can experience a long-lasting spontaneous remission with no therapy. So that was just one other fact that we didn't mention earlier. So shifting away from the more classical indolent lymphomas is mantle cell lymphoma. Typically we don't lump this together with indolent lymphomas. Historically, it was lumped together in some of the indolent lymphoma studies. It likes to involve the bone marrow, it loves to involve the GI tract. So really, almost all patients have advanced stage disease if you look closely enough and you do a bone marrow, upper and lower endoscopy with biopsies as part of their initial staging, then most patients do have advanced disease. For the uncommon localized stage 2 or stage 1 disease, radiation is recommended. Though again, because we know the pathobiology is such that patients are more likely to have advanced stage disease, chemoimmunotherapy is also considered appropriate to add to the radiation therapy in these patients. So it's a little stronger consideration to add something to radiation in patients with mantle cell, again, just due to the biology being different and that they're more likely to have occult distant disease, even if you can't find it at presentation. Advanced stage is very different than the more classical indolent lymphomas that we've talked about, and the treatment landscape is evolving such that our current treatment landscape here in the United States with NCCN guidelines is based on whether or not a patient has a P53 abnormality. So, and this is typically a mutation. So this is a shift away from what we do in other lymphomas, and hopefully we'll have similar biomarkers in the future to recognize high risk, follicular, etc. But the current recommendation is to check for P53 mutation. We know patients who are mutated, it's relatively common in mantle, up to a third of patients in some series or more. And those patients really should be offered clinical trial if there's an opportunity, because we know they do not respond well to chemoimmunotherapy. Younger fit patients, we tend to do high-dose therapy, autologous stem cell transplant consolidation, and consideration of rituximab maintenance. For less fit patients, we tend to do less intensive chemoimmunotherapy. And then there is this group of patients, about 10%, who have an indolent subtype. And this is usually more of a CLL-like presentation with blood, bone marrow involvement, and splenic involvement, or isolated GI presentation. They have a low tumor burden, a low Ki-67, a normal LDH. Typically, your IgHV is mutated, similar to what we look for in CLL. And one biomarker that can help recognize these patients is SOX11, which should be negative in this more classical indolent subtype. And those indolent kind of clinical picture of mantle cell lymphoma, we think of very similarly as follicular marginal zone lymphoma, such that you can observe those patients until symptomatic. And that's very different than all our other mantle cell lymphoma patients who get treatment at diagnosis. Outside of that indolent subtype, are there other patients that maybe don't have that classical indolent subtype, but are asymptomatic that might be appropriate for watch and wait? And the answer to that is yes. Peter Martin from Cornell is one of the earlier people to look into this question and has been, passionate about highlighting these patients. And up to a third of patients with mantle have an indolent course and actually may be able to be observed initially. So this is an initial study he did in 2003, just looking at initial watch and wait for patients with mantle cell lymphoma. And though the majority of patients, about 2/3, did need initiation of therapy in the first 3 months, you can see there's a small percentage of patients that went over 5 years without needing any therapy. And subsequent studies, including from Dr. Kumar at Sloan Kettering, have shown or suggest that the presence of a single high molecular risk feature like P53 abnormality should not exclude patients that otherwise have asymptomatic low volume disease from the potential to initially observe. I think that might change as we understand more about the pathobiology. As we see with CLL, we're studying immediate initiation of therapy with patients with P53 abnormality because we know those patients don't do quite as well. I think mantle cell and then hopefully the other indolent lymphomas will soon follow in those footsteps. But currently, isolated, high molecular feature in an otherwise low volume disease patient is not an indication for treatment. I just included 2 pearls here about Waldenstrom. Really, we're not going to go into it any more detail. In general, Waldenstrom is rare. There's about 1,500 new cases per year in the United States. Special considerations other than the usual watch and wait that we talked about. If you've got a patient that the trend of their IgM is such that you're worried they're at risk for hyperviscosity, that's a patient typically that should be treated even if otherwise asymptomatic or if asymptomatic. And another nuance is there's this group of patients with Waldenstrom macroglobulinemia that have very low volume disease, maybe 5% in the marrow. They develop some sensory peripheral neuropathy, and that's what led to the diagnosis. In those patients that have an IgM-associated peripheral neuropathy, whether it's due to anti-MAG antibodies or another reason, those patients actually do benefit from earlier initiation of therapy, typically with rituximab, just to help stop progression and potentially reverse the neuropathy. The sooner you treat the neuropathy in that situation, the better the chance the patient has for it improving or not progressing. So those are kind of 2 nuances about when not to watch and wait in Waldenstrom, when otherwise those patients would be very appropriate for observation. So with all of those different things in mind, basically, we're still at the point where we just observe if patients don't have symptoms for indolent lymphomas because we don't have any data yet that it changes long-term outcomes. But really, none of those studies involve the novel therapies that we have that now that we understand the pathobiology a little bit better of indolent lymphomas, like the immunomodulatory agents, the BTK inhibitors in certain subtypes, BCL2 inhibitors, etc. So as this treatment landscape becomes more personalized and targeted, we really need better ways to understand who may benefit from early initiation of therapy when otherwise historically we would observe. And again, as I started to mention before, I think that those ideas will borrow from what's happening in CLL and what's starting to happen in mantle cell lymphoma, that we need good predictive prognostic markers and models. What we currently have, we've got FLIPI, FLIPI2, M7 FLIPI, MALT, IPI. None of those can identify patients really with detail that are high risk of failing chemoimmunotherapy earlier rather than later, to have a short response. So if we can't even, pick who's at high risk of not having a long response to therapy, it's very hard to pick who might need earlier initiation of therapy when otherwise asymptomatic. Natural history of many of these lymphomas is measured, overall survival is measured now in decades rather than years. So until we can figure out better ways to have, shorter term outcomes in indolent lymphoma, it will be challenging to advance the field and to answer some of these questions about should we still be observing majority of patients who are asymptomatic in the targeted therapy era. So I think that brings us to some discussion, and this is my email, so I'm happy to be in contact with anybody in the future and to chat now.
Muchas gracias, doctora, por esta sesión. Un tema sin duda muy interesante y del que todavía hay muchas cosas que decir y que preguntarnos. Una pregunta muy interesante acerca, pues, de esta evidencia que hay en cuanto a la calidad de vida con la decisión de tratar o no tratar a un paciente. Parece que es muy claro el beneficio, pues, en cuanto a la angustia que genera el tener una enfermedad y no tratarla, pero hay evidencia de otros parámetros relacionados a la fatiga, funcionamiento físico y no solo estos aspectos psicológicos en los pacientes.
Ese es un punto muy interesante. Los pacientes con linfomas pueden tener síntomas, efectivamente, fatiga, que puede ser manifestación de la enfermedad, pero del estrés psicológico de tener una enfermedad por la que no exista una cura, aunque el tratamiento, y esto puede alterar mucho, por lo menos en la mayoría de los estudios, los criterios de valoración de la calidad de vida ya se están viendo y es importante, pero no estoy consciente de que haya algo específico en cuanto a los puntajes de calidad de vida por estrés por cáncer, pero creo que es importante cuando hablamos con el paciente no solo de la enfermedad, sino tratar de tener un análisis individual, qué tipo de vida tienen, cómo se va a ver afectado mental, emocionalmente, y normalmente antes de considerar como un inicio temprano de rituximab en estos pacientes, que es algo raro, normalmente les doy tiempo de ver cómo se sienten y no es algo que iniciamos luego. Sin embargo, un paciente que decida hacer esto inmediato puede ser 3, 6 meses, 1 año. Yo de veras, a mí me altera y sí puede ser una razón en la que tome una decisión de iniciar o de suspender la terapia.
De acuerdo. Muy interesante. Todo el público que quiera hacer preguntas, por favor, háganoslas y se las haremos a nuestros ponentes. Otra pregunta muy interesante y del manejo cotidiano es, en su práctica, en particular en los pacientes con linfoma folicular que decide vigilar, ¿cómo es este seguimiento? ¿Qué tan seguido lo hace? ¿Estudios de imagen o vigilancia clínica? ¿Cómo es en su práctica?
Pues con los pacientes con linfomas indolentes de estadía avanzada que son adecuados para una observación, una vez está el diagnóstico y si no hay un marcador elevado que me permita un monitoreo, aproximadamente los vuelvo a ver 6 meses después para ver cómo están con imágenes, si no es algo que se pueda dar seguimiento con la exploración física, pero yo trato de evitar estas imágenes porque muchos de estos pacientes permanecen asintomáticos durante décadas sin cambios. Y la verdad, los pacientes no quieren estar yendo a estos escaneos seguidamente, entonces a lo mejor 6 meses, 9 meses o 1 año, pero básicamente solo es observación.
De acuerdo, el doctor Meillón tiene una pregunta. Adelante, doctor.
Gracias, doctora Leslie, por su presentación. Quisiera comentar, es muy importante esta presentación de en qué pacientes debe uno esperar el tratamiento, debe uno solamente observar. Y quiero decir que actualmente tenemos un número creciente de medicamentos útiles para tratar en general los padecimientos linfoproliferativos. Y los médicos estamos constantemente escuchando nuevos medicamentos de gran eficacia, de buen perfil de seguridad. Y esto puede hacer que los médicos, particularmente los médicos jóvenes, tengan la necesidad de usar un medicamento eficaz cuando tienen un paciente con un problema de linfoma, aunque sea un linfoma indolente, para tratar de mejorar el pronóstico, aunque esto no siempre sea así, como usted nos ha mostrado. Quisiera preguntarle, en el caso del linfoma de células del manto, que constantemente escuchamos medicamentos de mucha utilidad en esta variedad de linfoma, y tomando en cuenta que hay variedades de linfoma de células del manto que pueden ser más agresivas, si usted puede volver a decirnos y comentar su experiencia personal de qué es lo que usted hace con un paciente con linfoma de células del manto para decidir que no debe recibir tratamiento.
Muy buenas preguntas y gracias por sacarlo aquí a los comentarios. La primera pregunta es, hablamos de que el paciente está nervioso por su calidad de vida, pero los doctores también tienen ese nerviosismo. Tengo el paciente con linfoma, hay que iniciar tratamiento, tenemos buenos medicamentos y no hay que preocuparnos, pero es importante evitar esta urgencia, porque sí, a lo mejor no necesitan tratamientos y pueden introducir efectos secundarios. La experiencia con rituximab ya tiene mucha experiencia, pero a lo largo de la pandemia ya tenemos anticuerpos que se pueden utilizar para mitigar algunos de los riesgos con rituximab, pero ya considerando las terapias nuevas, hay efectos secundarios agregados a largo plazo. También con la lenalidomida, y hay otras terapias aparte de rituximab, pero hay que preguntarnos si estamos agregando más toxicidad y si esto es para un beneficio potencial. Estos son los tipos de abordajes que yo sepa no se están investigando. La idea es identificar a los pacientes que no puedan tener ese beneficio de esa observación de largo plazo sin riesgo. Y yo pienso que la lenalidomida y los agentes moduladores también pueden ser buenos para algún linfoma folicular, y potencialmente algún día vamos a poder identificar un grupo que se beneficie de un inicio temprano de un abordaje inmunomodulatorio. Yo espero que esa es mi esperanza para el futuro, pero todavía no estamos listos. La segunda pregunta que me hizo usted fue el linfoma del célula del manto. Creo que este es de los linfomas más difíciles de manejar. Tratamos, y comúnmente estos no son linfomas de sentarnos y observar, opuesto a otros linfomas. Se ha descrito que sí hay un subgrupo de linfoma del célula del manto indolente que sí se puede observar, y esta opinión, desde que se publicó, esto se ha repetido y ya se acepta que si tenemos un paciente con una presentación muy indolente, un K67 muy bajo, pero una enfermedad de bajo volumen, y yo converso con el paciente de esta oportunidad, le considero si se fuera adecuada la observación, si lo considera, y dejo que el paciente decida. A un paciente con linfoma de células del manto que elija solo observación no es tan común. como 20% de los pacientes, más o menos, o 10% de los pacientes desean observarlo. Observo detenidamente un año más seguido o con mayor profundidad que con linfoma indolente, y los verifico, les doy chequeos más frecuentemente que a pacientes que solo tienen linfoma folicular.
De acuerdo. Y tenemos una pregunta muy interesante que es muy relacionada a esto que justamente acaban de comentar, que nos preguntan, en estos pacientes con linfoma del manto indolente, ¿cuál es su opinión de tratarlos con rituximab más ibrutinib y esto guiado por enfermedad mínima residual? ¿En algunos pacientes elegiría esta estrategia?
Yo diría que no. Comúnmente en células del manto he visto la necesidad de tratar o no como un poco blanco-negro. Si tengo un paciente que es adecuado por observación, no es alguien a quien necesariamente le doy inmunoterapia, como podría considerarse en algunos linfomas foliculares. Yo creo que la biología de las células del manto depende de las necesidades del paciente, quien está en buena condición física y es joven. Voy a tratar de darles el intervalo más largo posible sin tratamiento. También enfocarme en ese estatus PF53 para tomar decisión sobre los tratamientos a ofrecer. Y yo creo que dar un buen tratamiento así en células del manto es porque sabemos que los desenlaces no son tan buenos en general que con otros linfomas. Así que es por ello, yo creo que el abordaje de usar monoterapia con rituximab, al menos en mi práctica, como lo resaltan las guías, no es de la misma manera recomendado como lo que se considera con el linfoma folicular, por ejemplo.
De acuerdo, muy interesante. Por cuestiones de tiempo también tenemos que dejar aquí ya las preguntas. Muchas gracias, doctora Leslie, por haber estado aquí. Y regresamos en 5 minutos con la última charla del doctor Sal, que ya está aquí con nosotros. Les dejamos que se paren para ir por un café y regresamos en 5 minutos con el doctor Sal. Y de nuevo, gracias, doctora Leslie.
Hello, it's my real pleasure to be here today and to participate to this conference, and being closer to you right now in New York. I hope that I will be able to come and visit you in person. I think after this excellent talk by Dr. Laurie Leslie in the previous session regarding the first-line management of patients with follicular lymphoma, I was asked to address the management of patients beyond the first line of treatment. I would like to disclose that I have received financial compensation for different companies working in this area as described here, and that I will discuss a non-approved drug. So 2 years ago, my colleague from Memorial, Dr. Connie Bat-Levy, actually published this paper showing the overall survival and progression-free survival of patients with follicular lymphoma according to the different line of therapy. And I think there are a couple of messages from this paper. The first one, not surprisingly, is that while the median expected overall survival of patients newly diagnosed, as you can see on the top red line curve here, exceeds now 10 or 15 years. Unfortunately, when we take at a time of consideration, the time of second, third, fourth relapse, and later on, you can see that the median progressively diminished. These are, however, data collected in the 2000, in the first decade of this century. And why is that? It's because while we have an efficient first line of therapy, as discussed, we do see on the right that the second line of therapy is less efficient, with a median progression-free survival of 3 to 4 years, 2 to 3 years, and probably lower. It has been drawn to our attention now a couple of years ago by Dr. Carla Cazzulo that the patients that fail first-line treatment with R-CHOP have a dismal outcome, and that many of these patients will actually die. Half of them within 5 years after failing therapy. I think this is a very important message that probably needs to be slightly nuanced in recent time for different reasons. The first reason is that we have used commonly, when available, PET-CT at the diagnosis of lymphoma, probably repeated biopsy in patients with high SUV in certain areas, and probably then identified patients that were transformed at this time, and those patients are not treated with follicular lymphoma. This is shown also on this paper by Dr. Batlevi, showing that, again, there was a better outcome of the patients that were initially staged using PET-CT as opposed to CT. The second message is that we have more efficient treatment nowadays, even in the relapse setting, and that the outcome of patients with early progression of disease may not be as severe described earlier. A second point of consideration for this patient with POD 24 is that we have had recent information showing that a very high proportion of these patients with early failure after immunochemotherapy have in fact transformation of follicular lymphoma to a more aggressive lymphoma. When we looked on the left of the PRIMA study, you can see that while 20% of the patients at the time of relapse who had a biopsy had a transformation, this number is raised to 37% of the patients that were observed during the first year after the end of treatment. Similarly, our colleague from British Columbia have reported that 3/4 of patients with POD 24 progressing after bendamustine rituximab had a transformed disease. Well, these numbers varies. Again, there was about 19% of patients with transformed disease in gallium with a patient with early progression, and it may vary according to the search for transformation, new biopsy performed, but I think this is something to always take into consideration.
Consideración.
So the first thing I would like to discuss is a patient at first progression. And when they have the first progression, we have to ask a couple of things. The first thing that we have to ask is that a late relapse? Is that a patient with a low tumor burden? Is that a frail patient? And if this is the case, I think we should consider a couple of things, which is watchful waiting, not treating the patient immediately, rituximab single agent, or eventually radiation therapy. And we don't necessarily need to initiate systemic therapy. I would like to point this. This is in the PRIMA study with long-term follow-up. And this is the difference between the progression-free survival, which was evaluated by repeated imaging, and this is the curve on the left, and the median time to new treatment initiation, and that's the curve on the right. And you can see that in the observation arm, patients that receive rituximab chemo but no maintenance, the median time to progression in the observation arm was 4.1 years. This is this blue arrow. But in the treatment initiation, it was 6.1 years, so 2 years later. Similarly, the median time to progression in patients with maintenance was 10.5 years, and it was much longer in those patients. So progression doesn't mean necessarily initiation of therapy. Second thing is that for patients who have failed and had received rituximab retreatment is something that works. And this has been demonstrated many years ago in the early development of rituximab. We have always also published a series of patients years ago from my previous center in Lyon, and showing that you can reuse this drug without any problem, and it's probably as efficient, if not more efficient. The third point that I would like to mention is the use of radiation therapy and maybe different ways of using radiation therapy. We do know the possibility of using radiation therapy in patients with localized disease at diagnosis, and that for these patients using 24 gray, described here on the right, provide a better progression-free survival as compared to using a low dose, which is called the 2x2 gray or boom boom, which provides a lower PFS, but still a significant number of patients are controlled for a long period, and there is no overall survival. In fact, 75% of the patients receiving this low dose of radiation are responding. This has been reproduced by in our center by Dr. Yahalom and Dr. Umber, and there is some biological mechanism indicating that this low dose of radiation is really useful for some patient and can control the disease. And this is a symptomatic treatment that can be used in many patients if we don't want to retreat them with systemic therapy or bendamustine rituximab. And here again, we have to consider different situations. The first situation is that the patient have never received immunochemotherapy. They were managed in the first-line setting with observation, with rituximab single agent or with radiation therapy. And I think at that time, I think it's really the time to use immunochemotherapy or rituximab lenalidomide. I will discuss that later, because these are really the treatment that have shown to improve overall survival in this patient. So if they have not have received that initially, I think they should receive it at the time of relapse if there are criteria for treatment. If they have already received immunochemotherapy, I will discuss the possibility of using R-square, rituximab lenalidomide, repeat rituximab and chemotherapy. And I will discuss the different form of consolidation we can discuss with this patient, either maintenance or autologous stem cell transplant. So that's one of the studies that have been done in patients that relapse after first-line therapy, and these patients were receiving either CVP or CHOP. And in the Gallodin studies, there was a comparison of bendamustine as a single agent versus bendamustine plus obinutuzumab. We published the follow-up of this study some years ago. And as you can see, the combination of obinutuzumab, bendamustine in these patients that were assessed as being rituximab refractory provide a significant higher progression-free survival. About 50% of the patients have freer progression, and also provide, compared to bendamustine, again, an overall survival benefit. So this is something to take into consideration. So we have this data of bendamustine after CVP or CHOP containing regimen. Repeating bendamustine may be sometimes hazardous because of the hematological toxicity that is associated with that. And usually we have to limit that to 4 cycles. What is clearly missing, and that's the reason I have put this picture here, is that do we have data regarding CHOP after bendamustine? In fact, we are missing this data. They were not really published in large series, and probably we will try to gather them in the near future. We also have to take into consideration that some classical chemotherapy regimen may also work for some patients, especially if we want to envision transplant. A few words about rituximab maintenance or obinutuzumab maintenance, if you use obinutuzumab, was this meta-analysis that was published some years ago, looking at all trials that randomized patients between no further treatment observation versus rituximab maintenance. And in this meta-analysis, as you can see, if we look at patients with relapsed or refractory lymphoma, there was a tendency, which was significant, for the reduction of the risk of death for those patients that receive maintenance. So I think if you haven't used rituximab maintenance in the first-line setting, it's probably time to considering in the second-line setting. Having said that, we are in the time where we are just progressively getting out of pandemic with a virus that have been very deadly in our patients with hematological malignancies. And I think we should probably now weigh the risk and benefit of using rituximab maintenance for these patients that have become more vulnerable to the COVID infection than in the past. The second point is a consolidation with autologous stem cell transplants, which was a strategy that was used by many colleagues worldwide, including our group in France for years. And this is a paper published by our colleague from Germany now 4 years ago, who look at patients that had late progression, treated with and without transplant, and there were no difference. But when they look at the patients that had an early progression within 2 years, received transplant, this is a green curve here, or were not receiving transplant, you can see that this is a very dismal curve, and this is true in progression-free survival and overall survival. Based on this data and other data coming from the United States, many have recommended this strategy. However, these are patients that have relapsed after first-line therapy, and what we don't know is how many of these patients have transformed. And when we look at the same kind of patient in the PRIMA study, we look like the overall survival of those patients that at the time of relapse had continued to have a follicular lymphoma histology was not bringing an overall survival benefit, maybe a progression-free survival benefit, but no overall survival benefit, while this overall survival benefit was very clear for those patients with transformed histology. So again, when we look at this retrospective data, looking at the role of transplant in patients with follicular lymphoma type of relapse, just keep in mind that some of this data did not necessarily examine whether or not there was a transformation at this time. So a couple of years ago, we discussed what was the role of hematopoietic stem cell transplant in patients with follicular lymphoma. And based on this nice data, which was an ABMT study, at this time, patients were not receiving rituximab in the first line. And I can see the median progression-free survival was quite impressive. So maybe it's still an appropriate treatment for some patients. We discussed that allogenic is probably not to be considered until patient had failed autologous transplant. And we didn't find an indication for a firm indication regarding autologous or allogenic transplant. And I will say nowadays, with the availability of CAR T therapy, at least in some places, I think autologous stem cell transplant is going probably to be used later in line of therapy. One of the new regimens that appeared in patients with follicular lymphoma was a combination of lenalidomide plus rituximab. And this was published by my colleague, Dr. Leonard, across the street in Cornell Hospital, showing that the comparison of patients that received rituximab single agent versus R-square were associated with a higher progression-free survival benefit. As you can see, the median PFS for those patients receiving R-square was exceeding 3 years, as I said, by the independent committee, whether it was just more than 1 year for those patients that received rituximab. Furthermore, in this study, a subgroup analysis restricted to follicular patients showed an overall survival benefit. So clearly, I think that rituximab and lenalidomide is a good treatment for this patient. However, in this study, patients that were recruited were not rituximab refractory and were probably patients with better prognosis candidate for rituximab only. But I will just draw your attention with the results that we just published in the first line setting and that you discussed already with Dr. Leslie, which was a comparison of rituximab lenalidomide versus our chemo, showing an exactly similar outcome of the patient in terms of progression-free survival and overall survival. These are obviously patients in the first line setting, but I suspect that the use of R-square in the relapse setting compared to our chemo will probably lead to similar results. One word of caution, another one, regarding patients that eventually may have received rituximab lenalidomide in the first line setting. And data from Houston that were presented some time ago suggest that for these patients, half of them had received immunochemotherapy, half of them have received another line of therapy at time of relapse. There was a better control of the disease as they received chemoimmunotherapy. So if you use a non-chemotherapy approach in the first line setting, I will recommend using immunochemotherapy in the second line setting. So that was the second line setting, and then discuss a little bit later what happens if the patient have received already 2 lines of immunochemotherapy of R-square, and things like that. So again, some patient may be considered for a more gentle approach, but let's discuss the other patient. Obviously, if the clinical trial is available, that's a good solution. Otherwise, we tried with one of my long colleagues, Dr. Qualls, to define what were the options for this patient. And we separated these options in options that were a little bit more intensive, which will lead to deeper and more prolonged response, for those that were less intensive and probably oriented towards the chronic management of the patient. And we said at that time, with the drugs that were approved in the United States, CAR T-cell will be a first choice, chemotherapy plus anti-CD20 can be reused, and R-square can be reused. And because of CAR T-cell being available, we thought that autologous stem cell transplant may be displaced in later line. PI3 kinase inhibitor, tazemetostat, rituximab, R-square and eventually radioimmunotherapy, palliative radiation could be also used. So let's go back to the data that supported this statement. So as we know, B-cell in follicular lymphoma are dependent from extracellular signals that are mediated by the B-cell receptor and other chemokine receptor. And these signals are giving survival signal into the cell mediated by the PI3 kinase or by BTK. So inhibitor of these drugs have been developed and have been made available for certain patients. Well, I drew this slide like 1.5 years ago, but as you can see, while there were at that time 4 PI3 kinase inhibitors available in the United States, recently 3 of them have been withdrawn for the market for patients with follicular lymphoma, given the frequency and severity of side effects encountered by the patient. The only one that remain available is actually copanlisib, which is different from the other one because it's a drug that is administered intravenously. Recent data presented by my colleague, Dr. Matazar, have compared the use of copanlisib versus rituximab copanlisib, suggesting that there was an advantage of using copanlisib with a prolongation of a progression-free survival as compared to rituximab single agent. I think that these data are not better than the use of R-square, which is probably less constraining for the patient. And furthermore, when we look at patients with follicular lymphoma, as you can see, the median PFS was only of 4 months, while patients were coming every week for the infusion of copanlisib. So this is not a drug that we are using frequently. While years ago, we learned that ibrutinib was not effective in follicular lymphoma, there were some recent data suggesting that another PI3 kinase, ibrutinib, may be useful. And that's the result for ibrutinib, sorry. And recently, during the ASCO meeting, Dr. Flores, Dr. Zanzani, and colleagues presented this study where they compared obinutuzumab, another anti-CD20 agent, versus a combination of zanubrutinib plus obinutuzumab in the so-called Rosewood study. And as you can see, there was an increased overall response rate with a combination of zanubrutinib, obinutuzumab versus obinutuzumab alone, an increase almost double of complete response rate, an improvement of progression-free survival, and a non-significant trend toward possibly an improvement of overall survival. While this drug is not available yet in this setting, but it obviously brings some questions regarding the role or the potential role of BTK inhibitors in patients with relapsed follicular lymphoma in the near future. Another targeted therapy has been made available recently in some regions, which is the first drug that targets the epigenetic machinery in patients with follicular lymphoma. This drug is tazemetostat, and as you may know, EZH2 is a component of the epigenetic that restrict the tumor B cell within the germinal center. And in about 20 to 25% of the patients with follicular lymphoma, there is an oncogenic mutation of EZH2 that further reinforces this phenomenon. Well, tazemetostat blocks the enzyme, either mutated or unmutated, so it's active on both forms of the enzyme and on both categories of patients. And as you can see, there was an interesting response rate, about 60% of the patients with a mutated gene of EZH2, and about 30% of the patients without a mutation. These results are summarized on this table that we published 2 years ago with my colleague and friend, Dr. Morschauser. As you can see, the overall response rate for patients with EZH2 mutated was 69%, but only 13% of these patients had a complete response rate. And the median progression-free survival and median duration of response were around 1 year. It's, however, a very well-tolerated drug with very few grade 3/4 events. While in the wild type, while the response rate was lower, there was also a duration of efficacy, which was in the range of 1 year with similar efficacy. So in the United States, this drug has been approved. It has been used. I will say it's a tool, but it will not probably at this time change the outcome of this patient on the long run. Well, more interesting were the recent development of CAR T-cell in patients with follicular lymphoma. One of the first results that were published was the study to which we contributed, which is called ZUMA-5, which was published by Dr. Karen Jacobson last year in Lancet Oncology. So as you can see, for those patients that were heavily refractory, multi-treated with follicular lymphoma, treated with oxycaptagen siloleucel, the overall response rate was of 94%, with the majority of patients, 80%, achieving a CR. Very few patients were in partial response, very few patients failed. Well, if you look at the progression-free survival curve, there is here on this curve patient with marginal zone lymphomas, that's another discussion. But for patients with follicular lymphoma, as you can see, the median has not been reached here around 2 years, but you can expect that eventually some of these patients may later relapse. As you know, CAR T-cells are not devoid of side effect, and the majority of these patients had a CRS, cytokine release syndrome, including 6% with grade 3-4 CRS. Many patients had to use anti-IL-6 tocilizumab steroids. A few were in the ICU, and probably more preoccupation. Half of the patients had neurological events, 50% of them grade 3-4. Another study with a different CAR T-cell, tisagenlecleucel, was published recently by another group of investigators. And again, we had an overall response rate of 86%, complete response rate of 70%. The median progression-free survival was about 30 months. What was interesting is that the toxicity appeared to be lower. Here, as you can see, there were very few grade 3-4 CRS, very few neurological events in general, and less use of tocilizumab of steroids. Recently, during the EHA meeting, Dr. Michael Dickinson presented a head-to-head comparison based on published data. This is not a trial of the two CAR T-cell, suggesting that they were equally efficient while there were more toxicity with oxycaptagen as compared to tisagenlecleucel. Now, today, both CAR T-cells are available in the United States for those patients, as well as in Europe, and we may expect also a third CAR T-cell becoming available in the near future. But maybe the major change for patients with follicular lymphoma that is just at the short horizon is the presence of new drugs, which are bispecific antibodies that bind CD20 for the majority of them on the tumor cells and bind CD3 and T cell, thereby activating T cell and activating their cytotoxic potential with the release of granzyme and perforin and tumor cell death. One of them has been developed extensively in follicular lymphoma and is called mosunetuzumab. In a single-arm pivotal phase 2 study with patients with relapsed and refractory follicular lymphoma have received at least 2 lines of therapy. As you can see, with standard inclusion criteria, all these patients should have received at least rituximab and alkylating agent. The way the drug was administered with this increasing dose, what is called step-up dosing, a very low dose at day 1, a higher dose at day 8, and a much higher dose at day 15. And then patients were receiving a second dose at cycle 2 every 3 weeks, and then a lower dose for 8 cycles if the patient were in complete response, 17 cycles if they were in PR. There were no hospitalization of the patient. The response rates that were observed in this trial are, I will say, still quite impressive, with an overall response rate for patients, the relapse of patients that responded. You can see that there was a significant activity in all categories of patients. Most of the overall response rate is in the range of 70 to 90%, and the CR rate are in the range of 50 up to 70%. And based on this data, a couple of other trials are continuing with this drug. So progression-free survival is only on 18 months. What should be noted is that the first injection of the drug is accompanied with some side effects, which correspond to a cytokine release syndrome, which needs to be managed with antipyretic drug, antihistaminic drug, and with a few patients, but randomly, with tocilizumab. But for this drug, mosunetuzumab, I will say it's a rather well-tolerated drug for patients with follicular lymphoma. There are a number of other anti-CD3, anti-CD20 antibody being developed, including glofitamab and epcoritamab, that in vitro appear more potent than mosunetuzumab, but probably associated with a higher risk of side effect and may not be the optimal drug for patients with follicular lymphoma. Less data are presently available for the other drugs. So I think, as you can see, while we published less than 1 year ago first schema with the different options, options are continuing to change. The first one is that we had at that time 1 CAR T cell available. Now we have at least a second one in the United States. We probably don't have access to PI3 kinase inhibitor overall. We will soon have access to bispecific antibody. Mosunetuzumab has been approved already in Europe by the EMA, and maybe in the near future, zanubrutinib. So what is down the road now? These are the drugs that are discussed, but there will be other drugs that will be probably continue to develop in the field of follicular lymphoma. Antibody drug conjugate may be useful. Tafasitamab, an anti-CD19 antibody, is currently in clinical trial, as well as an antibody against CD47, which prevents numerous bispecific or trispecific antibody. And obviously, the combination of these drugs can be envisioned in some circumstances. Well, is there a standard of therapy? Again, Carla Cazzulo and colleagues presented recently a very nice study looking in the real world data of what are patients receiving when they are treated with follicular lymphoma. And as you can see, these are patients that receive either rituximab single agent, rituximab CHOP, rituximab CVP, rituximab bendamustine. And you can see that in the second line, a large number of patients still receive chemotherapy. Another part receive novel therapy or probably R-square. Some still receive rituximab single agent. And if we go to the third line of therapy, again, you have a variety of approach. So I think the key message here is that there is probably no standard of care for this patient, and we really need to individualize therapy for our patient. Keeping in mind that when patients have survived at least 2 lines of therapy, their outcome is probably not that bad, as we just recently published with another group of investigators. So a few takeaways regarding the management of patients in follicular lymphoma in the relapse setting. First of all, the choice in the first-line setting is important. And we know that we can achieve long-term disease-free interval. It is possible with immunochemotherapy. It is possible by adding maintenance. There is obviously, again, the concern of the COVID pandemic for our patient, but I think we can probably continue to improve the outcome of the patient in the first-line setting. A second point to underline is that not all patients with progression of lymphoma need to reinitiate therapy, and we always need to assess patient needs and patient wishes. Some patients may prefer to wait until they reinitiate therapy. Having a lymph node that grows from 1.5 to 2 centimeters is probably not an indication of therapy. And some patients may prefer to discuss more intensive treatment leading to longer treatment-free interval versus treatments that are more mild, less constrained, but probably a little bit less efficient. And I think we really need to discuss that with our patient. A third message is that obviously all these treatments are accompanied with short and long-term toxicities. These patients are going to survive for a long-term period. And again, we need to be mindful about this toxicity, and that's another reason to individualize therapy. Finally, while many patients with follicular lymphoma will die from their disease, this is particularly true for patients with histologic transformation. So doing a new biopsy at the time of any progression is important. I would just like to conclude with this slide that we published a few years ago with my colleague from Mayo Clinic and my colleague from Lyon, showing that, you know, the risk of death is patient without transformation to die from lymphoma is relatively low, while for those patients that had a transformation, this is really the patients that don't do well. Having said that, I would like to thank you for your attention, and we'll be very happy to answer any questions you have, again, regarding this presentation or the management of patients with follicular lymphoma in the relapse setting.
Pues muchas gracias, doctor, por esta sesión muy interesante. Sin duda, cosas nuevas y muy emocionantes que están sucediendo en el tratamiento de esta enfermedad. Y tenemos algunas preguntas muy interesantes de la gente que está escuchando. Los que no hayan puesto aún su pregunta, por favor pónganla en el chat para que la podamos hacer aquí. Pero una pregunta muy interesante es acerca, pues, de estas transformaciones, que queda muy claro la importancia de rebiopsiar a los pacientes al momento de la recaída, pero la pregunta es, en casos en donde por el sitio las lesiones que más captación tienen sean técnicamente difíciles de biopsiar, ¿en algún escenario en particular consideraría asumir que es una transformación a un linfoma agresivo por el comportamiento clínico o las características del PET sin necesidad de una biopsia?
Pues sí es una pregunta importante, ya que como los colegas que hicieron esta pregunta, a veces no siempre es posible hacer otra biopsia y ni siquiera asistidas por ultrasonido. En nuestra práctica es importante y siempre tratamos de tener una biopsia cuando sea posible, pero si no es posible, hay circunstancias clínicas que dan origen a la posibilidad de una transformación subyacente, que sea un tumor de crecimiento muy rápido. Después de 3 meses ya tuvo el crecimiento del tumor o el paciente tiene un nivel muy alto de LDH cuando tenemos un nivel de 3, 4 veces más el valor normal, es un caso sospechoso de la transformación, o pacientes que rápidamente desarrollan síntomas B, degeneración de su estado general, también puede ser la sospecha de una transformación. Y también hay casos raros con hipercalcemia o con un síndrome metabólico que puede asociarse también a la transformación, pero habiendo realizado muchas veces las biopsias, a veces la transformación se encuentra donde uno menos lo espera y a veces uno espera la transformación y no la encuentra. Así que cuando sea posible hay que hacer la biopsia, y si la enfermedad no está accesible, y esto sucede en algunos pacientes, hay que considerar, sí, las características clínicas. Obviamente otros puntos a considerar es un PET, una actualización de una imagen por PET cuando sea posible, cuando haya mayor absorción de 20 o 50 SUV, es razón para considerar transformación. Sin embargo, no es una decisión blanco o negro, es importante si se puede hacer la biopsia. A veces los PETs no pueden ser tan claro como blanco y negro, y también, como digo, las características clínicas pueden ser indicativas de una transformación.
De acuerdo, creo que el doctor Meillón tenía una pregunta que quería hacer.
Sí, con relación a esta misma situación clínica, ¿tiene algún rol la biopsia líquida con análisis de DNA para predecir o diagnosticar una transformación cuando no es posible tener una biopsia del tejido?
Sí, sí, muy interesante campo, y esperamos que la biopsia líquida nos pueda ayudar a identificar con mayor precisión a un paciente con transformación. Como sabe, estas son técnicas que siguen en nivel experimental, se realizan en 1 o 2 centros. En Memorial estamos desarrollando un centro, pero estará disponible hasta en 6 meses. Pero los datos tempranos del grupo Stanford muestran, es el caso clínico de un paciente con linfoma folicular recurrente. La biopsia en un lugar no mostró transformación, pero la biopsia líquida mostró un par de mutaciones que se encuentran en casos raros de linfoma folicular, pero indica la transfusión a células B grandes. Este paciente fue manejado, está descrito en el documento de caso clínico, pero posteriormente la biopsia mostró la transformación que presentaba este mismo patrón de mutación que la biopsia líquida. Así que efectivamente sí es un campo muy interesante que tendrá que ser desarrollado y esto va a ser muy importante para los pacientes, pero pienso que estamos apenas en una etapa muy temprana y esta prueba no es disponible excepto en algunos centros que han desarrollado sus propias pruebas. Necesitamos más datos, pero claro, esperamos que sea una herramienta futura para ayudar a identificar a los pacientes que tienen o que transformen a una enfermedad más agresiva.
Gracias.
De acuerdo. Muy interesante. Tenemos también una pregunta muy interesante del público. Sabemos que pues, muchos de los primeros ensayos utilizando ya sea venetoclax o inhibidores de PD1 no han tenido grandes resultados en esta enfermedad, pero sí cree que hay un futuro para ya sea venetoclax o inhibidores de PD1, PDL1 en el manejo de los linfomas foliculares con algunas otras combinaciones.
Pues pienso que es una familia distinta de fármacos. Venetoclax ha sido una desilusión en el linfoma folicular. Esto puede parecer una paradoja, a pesar de que sabemos que existe la translocación y esperamos que las células sean sensibles a la inhibición de este celto, la tasa de respuesta fue en el rango de 40-50%. También, en general, la duración del efecto fue la desilusión. Hubo un estudio por el doctor Sinsale combinando betuximab y vendatusmid que fue negativo en el estudio aleatorizado, así que no vimos que agregó mucho a la quimioterapia de estos pacientes. ¿Y por qué es esto? Pues es muy probable que la sobreexpresión de CL2 sea clave en el manejo de los pacientes con linfoma folicular, pero al momento de diagnóstico probablemente las células ya no dependen tanto en la expresión de BCL2. Hay muchas otras varias mutaciones que quizás dependan de otros procesos. Hay más limitaciones que la mutación ABCL2 y es posible que venetoclax no se una eficientemente a BCL2 en algunos casos. Esto es para venetoclax. Vamos a ver si los inhibidores BCL en general cambiarán el campo, pero pienso que pero no estoy tan confiado de que esto sea el caso en cuanto a los inhibidores PD1. Esto ha sido peor porque ha tenido resultados desilusionantes en pacientes con linfoma folicular. Hemos aprendido que aun cuando PDL1 se expresa en los macrófagos, no se expresa en las células tumorales y es posible que hay trabajo de la clínica Mayo que sugiere que algunos puntos de verificación inmunes estén involucrados. Hay un protocolo, pero los resultados no han sido sustantivos. Hay otros abordajes dirigidos a otros puntos de verificación que muestren una distinta actividad. Esto falta por definirse. Es difícil relacionar esto a las células T y a las células tumorales. Debemos aprender más en estos protocolos que están más dedicados a estas rutas de la enfermedad.
De acuerdo. Tenemos también otra pregunta muy interesante acerca de estos pacientes que tienen recaídas o progresión temprana en los primeros 24 meses. ¿Qué hace que estos pacientes sean biológicamente distintos y si esta característica de recaída temprana pudiera hacer que sean mejores candidatos para algún tipo de terapia en particular?
Pues, de nuevo, Pienso que tratamos de entender la biología de la enfermedad, identificando si los pacientes tienen características particulares, pero todavía no las identificamos. Y lo que dije, ya hay que recordar de nuevo, estos pacientes que progresan en los 24 meses, particularmente después de la inmunoterapia, en algunos lados tienen transformación histológica. Lo que no se sabe es si esto estaba clon presente en el diagnóstico o si emergió durante la evolución de la enfermedad o si es un clon nuevo. Hay trabajo del doctor Criddle en British Columbia indicando que algunas veces cuando los pacientes transforman no es posible hacer un rastreo a saber si el clon es una mutación en las biopsias previas. Puede ser que estos fueron clones de baja representación, niveles muy bajos o mutaciones nuevas, y esto explica la transformación. Ya sea esto válido con los pacientes de una progresión o transformación temprana, no sabemos, no todas las mutaciones dan lugar a la transformación y requieran manejo distinto con terapias combinadas o de rescate, o la discusión del trasplante en estos pacientes, o si ya se utilizó el régimen de rescate o la terapia de células CAR-T, que eso es lo que está empezando a intentarse. Hay pacientes que se les siguen tomando biopsias y no han mostrado transformación. Creo que todavía no tenemos una explicación clara de por qué estos pacientes son así ni de su biología. Mi tendencia es pensar que lo que hemos ganado es una combinación de quimioterapia, rituximab, CHOP y bendamustina. A lo mejor no sea un beneficio para estos pacientes en la configuración de segunda línea y que preferimos tener una intervención en Basimut R cuadrada o agentes nuevos, protocolos nuevos o una célula CAR-T específica. Rituximab ayudará a cambiar los abordajes, pero de nuevo todo esto son más recomendaciones basados en datos, porque no tenemos datos indicados que un régimen sea mejor en una configuración de recidiva de un paciente contra otro, sobre todo si consideramos únicamente a los pacientes con una histología preservada, una histología continuada del linfoma folicular y nos alejamos de los pacientes con transformación histológica.
De acuerdo, muy interesante. Hay otra pregunta también interesante, probablemente difícil de contestar, pero llama la atención ver pues tan buenos resultados con estos anticuerpos biespecíficos que están dirigidos contra CD20, y sabemos también que los resultados que se tenían con blinatumomab dirigido a CD19 tampoco eran grandiosos. ¿Cuál podrá ser la experiencia? ¿Es más bien farmacológica o hay una diferencia entre blanquear CD19 o CD20 en estos linfomas?
Pues pienso que ustedes conocen la historia de blinatumomab. Es una historia interesante para pacientes con recidiva. Los estudios que realizamos muestran que para la enfermedad progresiva se tiene que aumentar la dosis, y esto no pudo sostenerse en un grupo de pacientes porque presentaron efectos secundarios. La vida media de la molécula con una infusión continua lo explicó, y este es un fármaco muy difícil de manipular y es la razón por la que únicamente se utilizó para los pacientes con ACL. De hecho, los pacientes tuvieron un desenlace a largo plazo, pero no es un fármaco práctico. Yo no creo en la cuestión del CD20, CD19, más bien es la estructura del anticuerpo, la forma de la farmacocinética de obligatorizumab. Es una molécula de una vida media corta. Y aún más, y este es un campo que realmente es importante e interesante en el desarrollo de bioespecíficos, en realidad desconocemos si debiéramos tratar de estimular las células T con anticuerpos que tienen una afinidad muy fuerte de que da lugar a un impulso de la activación, y quizás después de este estallido y expansión de la activación existe un fenómeno de agotamiento, o a lo mejor debiéramos elegir un anticuerpo, pero en un modo menos estrecho tuviera un menor estallido. Y yo pienso que hay epítopes distintos por algunos anticuerpos y mantiene la diferencia en el desarrollo de la bioespecificidad, y esto explicaría los efectos secundarios, quizás por una estimulación muy fuerte de las células T. Y no sé, quizás como sugerí en cuanto a la reacción de los bioespecíficos con los linfoma folicular, a lo mejor sea la activación muy larga y que no sea tan efectiva en pocos días como efusión, y el efecto secundario sea distinto. Sin embargo, en el linfoma de difuso de células grandes sea menos efectivo que con el linfoma folicular, y algunos antibióticos son altamente efectivos, pero asociados con mayores efectos secundarios. Y las compañías, bueno, parece que las compañías están desarrollando, han decidido estos estudios para distintos tipos de linfomas. No todos los anticuerpos son iguales. Vina fue buena, pero difícil de manipular, pero los investigadores han tenido problemas de cómo estos bioespecíficos activan las células T que no son específicos a la expresión, y esto no es dependiente de los puntos de verificar, y es otra forma de estimular las células T que sean activas.
De acuerdo, muy interesante. Y tenemos una última pregunta muy interesante, que es: en el contexto de un paciente con un linfoma folicular en recaída, sin transformación, pero que fue resistente a la quimioterapia inicialmente y después responde, ya sea con alguna terapia blanco o algún anticuerpo biespecífico, si este paciente se beneficia de un trasplante autólogo, tomando en cuenta pues que tuvo resistencia a quimioterapia inicialmente, por lo tanto pues no lo consideraríamos quimiosensible.
Pues un tema a discutir interesante. Creo que no puedo dar respuesta. Es una pregunta que también tenemos, sobre todo con linfoma Hodgkin. En cuanto a los puntos de verificación en el linfoma folicular, creo que es difícil hacer este caso. Todavía creo que la quimioterapia de alto tratamiento después del tratamiento es un tratamiento muy efectivo. Los efectos secundarios son obviamente manejables, pero también tenemos el riesgo de las comorbilidades y mielodisplasia. Creo que esto es algo que se debe de utilizar con sabiduría. Si el paciente fue resistente a la primera línea de terapia o a la segunda, y la terapia con células CAR-T no son disponibles, creo que considerar el trasplante es un papel importante. Esperamos un beneficio a estos pacientes con una recidiva para considerar el trasplante. La verdad no sé, pero debemos recordar que el trasplante no solo un mecanismo para que la quimioterapia sea efectiva, sino se reconfiguran, se reconfigura el panorama inmune y tienen respuestas que pueden dar resultados buenos. Yo he tratado pacientes así antes de las células CAR-T, los pacientes que fallaron al tratamiento con quimio y sí respondieron a agentes meta, y sí los he considerado. Sin embargo, actualmente hacemos menos trasplantes porque tenemos más herramientas para los pacientes, pero pienso que sí se debe considerar y discutir estos casos con los pacientes, el trasplante, y yo recomiendo esta discusión, sobre todo conforme se tengan datos de mayor detalle.
Muchas gracias, una discusión muy interesante. Por cuestiones de tiempo ya nos vamos a tener que despedir. Le agradezco mucho haberse tomado el tiempo por estar con nosotros esta mañana y le dejo pues las últimas palabras al doctor Meillón para despedirse y clausurar la sesión.
Pues muchas gracias a los tres ponentes por excelentes presentaciones y en particular al doctor Sals. Agradecemos mucho su presencia. Como dije en un principio, ahora lo tenemos más cerca. Esperamos contar con él en nuestro congreso anual el próximo año. Le haremos saber con anticipación las fechas para poder tenerlo en México, si él así lo considera. Y pues muchas gracias a toda la audiencia por escucharnos en esta muy útil e interesante sesión sobre linfomas indolentes. Que tengan todos ustedes un buen fin de semana y muchas gracias.